Vanakkam. Ingrowing toenail is a very common condition that is very painful, frequently gets infected and prevents the patient from wearing his regular shoes and hence prevents him from regular activities. Before we talk about the management of this condition, we need to understand why it occurs, because if this is not corrected, even an excellent surgery will result in a recurrence of the problem. The first step of management of the ingrowing toenail is always conservative management, but in some patients, surgery may be indicated. As far as the surgical management is concerned, there are a few technical steps that need to be taken care of to achieve good results. This video deals with all the aspects of ingrowing toenail and the management. As far as the ingrowing toenail is concerned, the first confusion is with the nomenclature. Whether it should be called ingrowing toenail or ingrown toenail, unguis incarnatus, because the nail is the primary problem, or should it be called onychocryptosis as the nail is covered by the hypertrophic lateral wall tissue. In this video, for sake of simplicity, we shall stick to the term ingrowing toenail. Let us first understand the anatomy of the normal big toenail. This is the nail plate that is seen outside, but what we need to remember that the nail bed and the nail plate extend much more proximally, covered by the proximal nail fold as shown, and a little on the lateral sides also covered by the lateral nail fold. This nail bed is closely applied to the terminal phalanx bone by multiple fibrous septae. There are many types of this ingrowing toenail and we need to understand which type we are dealing with. The first is the neonatal type, which has a free nail margin which is not yet overgrown the tip of the toe. This needs only conservative management with massage till the free nail margin starts growing. This picture depicts the appearance of the ingrown toenails in neonates. Ingrown toenails can also occur in infants where there is a congenital malalignment of the big toenail. This is caused by a genetic malformation and usually undergoes spontaneous healing by about 2 years. The third type, or the adolescent type, is the most common presentation. This type is characterized by distal lateral ingrowing of the lateral nail folds. We shall deal about this in much detail later. The type of ingrowing toenail seen in adults is sharply bent at the lateral margins and requires surgical correction. There is a progressive transverse overcurvature that pinches the nail bed, hence also known as the pincer nail. The X-ray of such a toe will show a very wide base of the distal phalanx with osteophytes that are bigger on the medial than on the lateral aspect. The primary cause of the ingrowing toenail in adults is the widening of the base of the terminal phalanx, and as a consequence of this, there is a narrowing of the distal portion, and the heaped up distal portion of the nail bed pulls up the soft tissue, resulting in a traction osteophyte. And in these patients, usually the whole distal phalanx of the hallux shows a lateral deviation, whereas the involved lesser toes point medially. The adolescent type of the ingrowing toenail is the most commonly seen presentation. It is also known as the distal lateral ingrowing toe because that is where the involvement is seen. The etio-pathogenesis of this adolescent ingrowing toenail is the wide, markedly curved nail plate, the distal lateral corners of which have been cut obliquely, leaving a tiny spicule that digs into the lateral nail groove and finally pierces the epidermis when the nail starts growing forward. This causes a foreign body reaction with inflammation, granulation tissue, secondary bacterial colonization, and eventually infection. And the precipitating factors that lead to these problems are the usage of narrow pointed shoes, tight socks, hyperhidrosis, and juvenile diabetes mellitus. Basically, there are three stages of the ingrowing toenail as described by Hayfens. Stage 1 shows inflammation, swelling and pain only. Stage 2 shows non-healing wound with oozing and granulation tissue, and stage 3 is characterized by abscess formation and chronic induration of the lateral nail fold. Since the diagnosis is quite obvious, after doing the basic investigations and x-rays, the management can be planned. Management is either conservative management and surgical or interventional management. When we consider conservative approach, there are many techniques, but 5 basic things that we need to know are taping, packing, gutter treatment, the use of antibiotics and hygiene measures. The technique of taping consists of the usage of 2 to 3 millimeter wide tapes to protect the lateral nail fold from offending the distal nail edge. Sometimes a wisp of cotton soaked with antiseptic or disinfectant is inserted between the corner of the nail and the nail fold. This procedure is repeated on a daily basis, each time trying to use a bit more cotton till complete painlessness is achieved, and this can be used only for patients in stage 1 of the disease. Similarly, the insertion of a small guard like the intravenous drip infusion tube, which has been cut lengthwise, is placed between the lateral nail margin and the nail fold, and this is done under local anesthesia. It is left in place for a period of about 6 to 8 weeks till the inflammation subsides. The role of antibiotics in the treatment of the ingrowing toenail is quite controversial. Usually, it is given when the patient presents with inflammation or granulation tissue, and in these conditions, it is not a very clear indication. However, it is justified when given after the surgical procedure, as we need to cut through heavily contaminated area deep into the peri-ungual tissues. And of course, hygiene measures like foot baths and consistent foot hygiene for removal of putrid scabs play an important role in reducing the inflammation and hence the pain. As far as surgical management is concerned, there are 2 fundamentally different approaches. Those believing that the soft tissue is primarily at fault propose to take away the soft tissue so that there remains no substrate for the nail to grow into and cause inflammation. On the other hand, there are others who favor the view that a wide nail in relation to a narrow nail bed is the primary event and propose narrowing of the nail plate so that it can no longer grow into the soft tissues. There are many surgical options available, but we shall discuss a few of the commonly done procedures. The simplest procedure that is done is known as the nail plate avulsion. It is based on de-roofing the infective focus and assumes that healing will correct the problem. However, this procedure is associated with significant post-operative morbidity. When the nail regrows, the plate is still as wide as it was before and will therefore grow in again, almost invariably followed by a recurrence. A study even states that nail avulsion for treatment of ingrowing toenail is not only useless, but it is almost always harmful even for the treatment of infected granulation tissue. This is how a patient of mine presented after 6 attempts at surgical correction of ingrowing toenail. This subsequently healed with dressings alone. The second surgical option is wedge excision, which has a very high morbidity rate, as healing of the wound takes 3 to 6 weeks in many patients. It is also mutilating as the lateral nail folds are removed and the nail is no more ensheathed by them. The nail subsequently grows narrow, distorted, onycholytic, thickened, discolored and deviated. There is another procedure called the reduction and removal of the lateral nail fold. Due to the foreign body irritation by the ingrowing nail, the lateral nail fold often becomes swollen and overlaps the lateral aspect of the nail plate and develops granulation tissue. This surgery consists of excision of a fusiform piece of skin from the lateral aspect of the distal phalanx and suturing, which pulls up the exuberant nail fold laterally and away from the offending nail. The Van den Bosch technique used to be a popular procedure where a big chunk of soft tissue of the lateral nail fold is taken out down to the bone. After cauterization for hemostasis, the defect of approximately around 1.5 by 3 centimeters is left for secondary intention healing. Here, neither the nail plate nor the matrix or nail bed are touched. Cosmetically, the results are good, but healing takes several weeks. Kenu advocated a radical nail bed and matrix ablation. This became later known as the Zadik's procedure. Here, a proximal nail fold flap is raised and the entire nail bed and matrix proximal to the lunula are excised. The problem with this technique is that it shows around 60.5% recurrence and it is far too radical. The SIME operation described for ingrowing toenail consists of resection of the nail bed and matrix, amputation of the distal half of the terminal phalanx, and defect closure with a flap formed by the ridge skin of the tip of the toe. It results in a shortened and bulbous toe, but it is not free from recurrences and the technique is mutilating and obsolete. Now we shall consider the technique of segmental matrix horn cauterization with phenol. It is extremely simple, time-honored and safe with a recurrence rate of between 1 and 2%. Under local anesthesia, phenol is used to cauterize the matrix on the lateral aspect of the nail. Phenol is advantageous because it is a chemical cauterant and thanks to its protein coagulating power, it reduces bleeding also. It is a potent disinfectant and hence post-operative infection is rare. And lastly, it has got some local anesthetic activity also and hence diminishes post-operative pain. And finally, the commonly done Vinograd method, which leads to a narrowing of the nail with a very high cure rate in ingrown nails. It consists of excision of the lateralmost segment of the matrix and plate and the lateral nail fold. Before going into the actual surgical procedure, we shall try to understand the concept of this surgery. It consists of an incision on the proximal nail fold on the lateral aspect, raising both the proximal nail fold and the lateral nail fold and excising the lateral part of the matrix and the nail plate along with the lateral nail fold. This shows the cut section of the toe showing the involved lateral nail fold and the ingrowing part of the nail plate. This shows the lateral part of the matrix and the nail plate and the involved part of the lateral nail fold which is going to be excised. Now the defect after excision of the said segment is shown and the healing that occurs. Having decided on the surgical management, we need to counsel the patient and his attenders. The consequences of the surgery and the time for healing should be explained. Some patients can have bilateral ingrowing toenails and some patients can have both the medial and lateral side of a single big toe being involved. When the involvement is bilateral, both sides can be done at the same sitting. However, when it involves the medial and lateral sides of a single big toe, I prefer to do it in two different sittings to avoid complications. We also need to explain the procedure details to the patient, the anesthesia under which it is going to be done, usually local anesthesia, the use of a tourniquet, usually a pneumatic tourniquet at the level of the leg or a constricting tourniquet at the level of the base of the big toe, the dressings that the patient will need after surgery, the need for foot elevation and absolute bed rest, and the complications that can occur like the scar formation, the deviation of the toe or post-surgical raw areas. This surgery is usually done as a day care procedure. We shall consider the steps of the procedure under preparation, anesthesia, technique and post-operative care. The patient is in supine position and I usually use a pneumatic tourniquet tied at the level of the leg. Even when the procedure is done under local anesthesia, the tourniquet is usually tolerated for a minimum of 15 minutes with the patient very comfortable. A bipolar cautery is also very essential. Usually the procedure is done under local anesthesia by giving a digital block to the involved toe. Sometimes general anesthesia is given if the patient is very apprehensive. First, about 4 ml of 1% xylocaine mixed with 0.25% bupivacaine is given on the medial side of the big toe, and the injection is made on the dorsal aspect at the base of the big toe as shown. The needle goes right in and the other palpating hand of the surgeon palpates the plantar side so that the plantar digital nerves are also anesthetized. Next, the injection is made on the lateral aspect of the involved big toe just as it was done on the medial side. Finally, a subcutaneous cuff of anesthetic is infiltrated from the second site to the first site over the dorsum of the toe. Now the marking is made with an incision marked over the involved side of the big toe to raise a proximal nail fold flap and to raise the lateral nail fold flaps. The skin incision is made first on the proximal nail fold. After making the skin incision, the skin hook is used to retract the proximal nail fold both medially and laterally. The incision is deepened down to the lateral edge of the nail plate. There may be adhesions between the lateral nail fold and the nail plate, and these too should be released. This is continued till the tip of the nail. Now the segment of that nail plate and matrix that is going to be excised is marked. It extends from the tip of the nail to the base of the nail bed under the raised proximal nail fold flap. The incision on the nail plate is made with the number 15 knife down to the bone through the nail bed. Similarly, the undersurface of the involved nail fold is also excised as it contains unhealthy granulation tissue sometimes, and sometimes it is fibrotic. This delineated segment is now excised in toto. This shows the excised involved nail bed with matrix and the contiguous portion of the nail fold that has also been excised. The wound is now inspected and any remnant of nail bed or the lateral nail fold that is diseased is excised. When this skin flap is now replaced over the defect, this is how it will look. Now the tourniquet must be released and hemostasis achieved. It is also important to apply cautery at the base of the nail bed where bleeding is most common. And this cauterization also helps to cauterize any remnant of the nail bed that may be present. A gentle compression dressing at this stage will also help secure perfect hemostasis. The wound can either be left open or sutured. If gross infection was present before the surgery, the wound can be left open. If the wound has not been sutured, it needs to be packed with povidone iodine gauze. If it has been sutured, a non-adherent layer of dressing needs to be applied over the suture line. Gauze pieces are applied and a Gamgee pad dressing is necessary because of soakage that can occur. Since it is a day care procedure, the patient must be advised absolute bed rest and foot elevation with antibiotics, analgesics and anti-inflammatory drugs to be prescribed. A dressing change is advised at 48 hours. Patient can resume normal activities after a minimum period of 1 week. Surgery done for bilateral stage 3 ingrowing toenails can yield good results with complete healing of the wounds. I hope you enjoyed the video. I enjoyed making it. Click on the subscribe button to stay connected with the latest in the basics of surgical procedures.